Good afternoon, everyone. I'm President Vince Price, and I'm delighted to welcome you to this very exciting event, the Duke-Margolis Center and Duke Alumni Association webinar on COVID-19. In this uncertain time, I'm reminded that the great strength of the Duke community is its people. From the providers who are treating patients at Duke Health, to the researchers who are conducting groundbreaking vaccine research in our labs, from the faculty who are innovating in new teaching environments, to the countless alumni who are serving communities around the world. Our global network of extraordinary Blue Devils is leading the way, addressing the unprecedented challenges we face. Today, you'll have a chance to hear about some of the most vital work taking place at Duke. The Duke-Margolis Center for Health Policy is helping policymakers design effective interventions that will save lives and protect the economy. Through research and education, the Margolis Center experts are working to improve the health and the quality of health care for everyone. The center was ready to respond, becoming a leading voice in the nation's response to COVID-19. This extraordinary effort fulfills the vision of Dr. Bob Margolis when he created the center in 2015. Bob is with us today, and I'd like to say thank you, Bob, for your leadership and your support of this vital work. We're so very grateful. Today promises to be a truly extraordinary event. Here with us is Margolis Center Director, Dr. Mark McClellan, one of the nation's foremost experts on public health policy, who you've likely come across already in media discussions of COVID-19, as he's been a major and a thoughtful public voice over these past months. Also with us is Trustee Emeritus David Rubenstein, who you may also have seen in one or more of his own insightful interview programs, and who, I'm so pleased to say, will moderate today's discussion about the coronavirus. I'm also grateful to Senior Policy Fellow Susan Densler, to Sophie Hurwitz, class of 2022, and Sahil Sandhu, who graduated just earlier this month. We're so grateful to all of you for participating in this timely conversation. And with that, I'm delighted to turn things over to Dr. Bob Margolis, Chair of the Duke-Margolis Advisory Board and the center's founding donor. He is a 1971 graduate of Duke Medical School and has been a leader in the managed care industry for more than 30 years. I'd like to ask him to begin our event by sharing with our audience his vision for the center and why he chose to support health policy at Duke.
Thank you so much, President Price. And Mark and David Rubenstein and all of those who put this session together. I'm very pleased to reconnect with so many colleagues, several trustees, David Rubenstein again, and clearly 1,000 or more of my fellow Duke alumni that have registered for this event. As Vince pointed out, the Duke Policy Center has really been front and center during this pandemic, thanks to the amazing work of our whole team. There's actually, in my lifetime, and I think probably in all of our lifetimes, there's never been a more disruptive moment in our history than this pandemic to highlight both the glories of medical science and the incredible work towards treatments of the COVID plague, much of that being happening at Duke, of course, but also, in my view, the glaring weaknesses of our health system in some aspects of its organization, of its public health infrastructure, of its data sharing capabilities, of its ability to coordinate and provide access on a equitable and cost-efficient and coordinated basis. The beauty, perhaps, or silver lining is that during severe disruptions that we're experiencing, probably a once-in-a-lifetime set of health disruptions, there's really never been a better time to figure out a new system, a future system highlighting the central opportunities, I believe, that face our Duke health policy opportunity. So as Vince said, why did I and my wife Lisa choose to support and develop this health policy center at Duke? And so if you'll bear with me just a moment, I'll take you on a quick journey through my professional career. It started, at least professionally, in medicine with the amazing foundation I got at Duke Medical School with most amazing professors and mentors that I still think of frequently as I think through health and health policy. Uh, After Duke, I quickly went through a fellowship at the National Cancer Institute in Bethesda, finished up at UCLA, and formed a practice with several like-minded internists where I practiced internal medicine oncology for several decades, but also moved into medical group management and policy. Joined many national organizations where I had the great privilege of chairing several, and therefore spent a bunch of time both at state legislatures and both testifying and lobbying in Washington, D.C. And I noticed something very interesting, at least to me at the time as a proud Duke alumni, was that when it came to clinical innovation and creativity and advances in medicine, Duke Health was always at the forefront. Always has been, and I'm sure always will. And congratulations to all the amazing people in research at Duke Health. But I also noticed that when it came to policy circles, and I was on several other academic policy boards, that Duke was just not present. And we just didn't hear from Duke around how to improve the health and healthcare of Americans everywhere. And so it seemed like an interesting opportunity for a collaborative approach at Duke that was different. I was on several policy advisory boards at other academic institutions, and they were all single dimensional. They were all tied to a single department. So I had the opportunity in meeting with President Broadhead at the time to talk about the history of Duke being an amazingly collaborative, cross-departmental institution that could understand that health care was broader than the great clinical care at Duke Health, but involved all the other aspects that were available at Duke, including public policy, law, engineering, and law, the other departments in Trinity College. And so between those conversations, and then with the amazing support of Gene Washington, our chancellor, and Sally, our provost, we launched the Duke Policy Center in 2015. And I'm very excited with the opportunities that lead us into the future, being able to bring Mark McClellan to Duke, who has been an outstanding leader, along with Jillian and Marta, have produced amazing results for our Health Policy Center to date. And I'm sure the future of this cross-campus collaboration across all these departments will yield the ability to understand health and health policy and use this nasty pandemic disruption to come up with a better health system for all Americans that's equitable, affordable, and coordinated. So with that, I will happily turn it over to our wonderful director, Mark McClellan, to give you a much more in-depth discussion of how Duke Health Policy has played a role in this COVID pandemic. Thank you, Mark, and thank you, David Rubenstein, for coordinating this session.
Well, Bob, it's great to be here with you and with everyone who's joining us today. And let me start out with a few words of thanks. First to you and Lisa for endowing the center, and then also to the President Price and the Duke University leadership for having the vision and support to let us do this in a unique way. As Bob said, we are a university-wide program aiming to bring an interdisciplinary approach to solving healthcare problems and population health problems in North Carolina, the United States, and around the world. And that reflects an approach that Duke very much takes of bringing different perspectives together to solve hard problems and not being afraid to get out there in the world, not just do the research, but make sure it has an impact. So we have a large part of our research team based in Washington, D.C., where they work with federal agencies on national convening, global efforts in conjunction with the research that we support here at Duke. And if we go on to the first slide, I'm going to walk you through a few slides about the center. That's what our mission is really about. And I'd like to highlight that we are about health as well as healthcare. And our key themes include transforming the way that healthcare works so it doesn't stop when people leave the office. It's really about getting out in the community, bringing health services to people where they need them, and focusing on the non-medical factors that interact with healthcare, or should, in order to get the best outcomes at the lowest cost to society. And also supporting biomedical innovation. It can transform the way that so many conditions and health problems are addressed. And as I said, we do this at not just a local, but a global level. And we also have a big emphasis on education. So helping policymakers, the broader public, and especially our leaders for tomorrow bring better solutions to these really hard, complex problems in health. And not surprisingly, this turned out to be a good fit with the pandemic. So our pandemic response is really focused in three major areas, reflecting the way that pandemics generally work. First off, and I think this is the next slide, is helping with successful containment and reopening of the country. By definition, when pandemics begin, you don't have any medical treatments that work, not therapeutics, not diagnostics. But for reopening, we can make fast progress on testing to better detect the virus, and new ways to move beyond just the extreme social distancing measures that the United States and other countries had to put in place at first to flatten the curve and prevent the unmitigated spread and the health consequences of the pandemic. We need to get beyond that as quickly as possible. And so that's one part of our response. A second part is in making our healthcare system work better. Healthcare reform in the era of COVID-19 is going in the direction that it was already headed, towards telemedicine, towards more care at home, towards more emphasis on prevention, risk detection. We've just seen a massive need to accelerate that progress and then find ways to sustain it. And then third, the way out of a pandemic is really through medical progress on developing the treatments and in the end, the vaccines that can get us back to being immune, to not having an impact from the virus. So the more that we can accelerate that medical progress, the more effective our recovery will be. And those are responses go into those categories. But again, I want to emphasize the importance of communication and education. So that's the last big piece, educating leaders, engaging with policymakers at the federal, state, and global level, and the broader public, because there's so many things that people can do. And I would also like to give a special thanks to the Duke alumni. We made connections as a result of this effort, to work that many of you are doing, to questions that you have, to suggestions that you have, everything from how to help reopen Duke University effectively to how to make progress on vaccines and diagnostics and new ways of delivering care. It's been a great partnership, and we're looking forward to more. So I wanted to provide on the next slide a little bit of context as of where we've been and where we're headed. A lot of people ask me, I'm sure you ask you all as well, when did you know that this was going to be a big deal, something that would be on the scale of an unprecedented pandemic? And if you do the first step on this, we started having some focus on this effort back in January. I was FDA commissioner during the SARS epidemic, worked closely with then my special advisor, Scott Gottlieb, who was recently FDA commissioner. And having lived through some of these previous threats of pandemics, Scott especially, from our previous work, was focused on some of the early outbreaks and the signs that this could be a very serious effort. We also knew when some of our global activities started to be impacted, collaborations with the National University of Singapore and the health system in Singapore, for example, in February, when they were already going into very aggressive response mode, the potential for serious spread and impact was there. So we started out our response work during that time period, and as the clear implications were felt in the United States, especially around issues like testing, being able to detect the virus, let alone contain it, we launched a number of activities, and some of those are shown on this slide as well, especially focusing on what we knew we needed to do to get out of this, and that's accelerating new therapies, vaccines, and diagnostic testing to better identify and then be able to treat and move beyond the pandemic. But then a lot of work related to improving diagnostics, because there was a lot of potential for making tests better, for both detecting the virus and helping to identify who might be immune to it. So a series of reports focusing on how to move beyond the extreme social distancing measures, the stay-in-place lockdowns that the country was imposing in March, was what we were focusing on as the next step. These sets of recommendations led to, if you go to the next steps here, an influence on the guidelines that the federal government put out. Our reopening plan for the country, our containment plan, were reflected in the criteria the White House laid out, that Ambassador Birx laid out for reopening the country, and that many states are in the process of following to a greater or lesser extent now. And then more recently, our work has especially moved to focus on the changes needed in healthcare, the changes to get to better therapeutics as quickly as possible, and then making sure we're implementing our surveillance steps effectively. And on to the next slide, I just want to highlight a reference for those of you who want to track what's going on. We converted these recommendations that we had made and the recommendations from the White House into a set of metrics. We're doing this in collaboration with a number of other organizations around the country. We're focused on reopening effectively. This website, covidexitstrategy.org, is a great place to track what's going on day to day in many of the key recommendations that we and others have made to reopen effectively. Things like getting the case trends down in a state so that you can be confident that your healthcare system has sufficient capacity, and increasing testing capacity to the point where most tests are negative, you're detecting outbreaks early, and you're also implementing steps for containment by tracing the contacts, having the capacity to trace contacts. What we've seen, though, is that most states, almost all states, have gone ahead with a gradual reopening without meeting all of these conditions, particularly conditions related to the 14-day trends in cases. Many states are still having increases, and also related to testing and contact tracing, not where we'd ideally like it to be, like you see it in Germany or New Zealand or other countries that have more effective containment today. And next slide. For that reason, we've recently, and this is just this past week, a full page op-ed in USA Today, taken some further steps to try to engage with governors, states, federal policymakers on how to reopen effectively under these imperfect circumstances. In this circumstance, we're particularly putting an emphasis on watching what's happening in trends in hospitalizations. And if you go to the next slide, what we're seeing is increasing testing capacity. That's a good thing. And that may also be contributing to why we're seeing an increase in many states in cases per day. The overall trend in cases is going down, but that's primarily New York, New Jersey, places that had very big outbreaks early, having continued reductions in cases. In many other states around the country, the trend is upward, but we've seen a flatter trend in hospitalizations per day. So that suggests that the steps that we are taking with an increased testing and more steps to contain outbreaks in high-risk settings like nursing homes and food processing plants are having some effects, but it's not to say that there aren't or won't be potential spikes or other issues coming up. So next slide. We also are tracking what's going on by state, because this is a very different experiences now around the country, with states like New York and New Jersey continuing to hit hard early, but continuing to show declines in cases. And on to the next slide, more case increases happening in other parts of the country, not just in some states in the Southeast that reopened early, like Alabama and Mississippi, but also in Maryland, Virginia, some of the New England states, Illinois, Nebraska. And these are areas where there are more localized outbreaks, not yet translating into spikes. That's what we want to avoid. What we've been emphasizing recently to governors and policymakers should lead to a pause or backward steps in their reopening efforts. But it is a concern. So for example, in Montgomery, Alabama, if you look at our tracking, the capacity of the healthcare system is starting to be challenged by these increases in cases. And you don't want to wait for that to happen, because the hospitalizations are a lagging indicator behind what's actually going on with transmission in your community. So our work in these areas continues. I want to shift gear and talk for a couple of minutes about the other major areas where we're undertaking work in moving healthcare from being about services that people typically get in a hospital or doctor's office to being about solutions that are focused on people's needs that can often be addressed at home or in the community. We've seen a huge shift in the last few weeks towards increased use of telemedicine and home-based care. What we don't yet have is full infrastructure to support that, to help healthcare organizations like Duke that are supporting community-based efforts in Durham County to do testing and early detection of cases, identifying and helping people who are at risk get tests when they need it and get the care they need without being exposed to risks in the community or in the hospital. Steps to make more services available, not just telemedicine visits, but remote monitoring, home care, other approaches that really will, I think, change healthcare for the long term, but haven't yet been part of the way that we pay for healthcare and our policy. So we're trying to match that up to give the healthcare organizations that are struggling so much today, they've lost a lot of money, they've in many cases been hard hit by the outbreaks, to give them a path forward to a new way of delivering care in the future. And of course, the way out, as I mentioned earlier, as shown on the next slide, depends on what we do with therapeutics. There are a number of treatments in development now that have the potential to improve outcomes and reduce the impact of the pandemic before we get to vaccines. Antivirals like remdesivir, drugs based on antibody responses, so either antibodies from people who have recovered or synthetic monoclonal antibodies that neutralize the virus, as well as treatments that can reduce the severity of cases of COVID-19 infection, which seem to be mediated when people get to the point where their lungs are shutting down and they need lots of organ system support in an ICU related to an overly aggressive immune response by their own bodies. So modulating treatments to reduce the severity of the pandemic. While those are in development, there also is this unprecedented effort through a range of new vaccine technologies, some of which we've used before, some of which, like mRNA, are new. And this is not about a race to the finish, which vaccine can get there first, but how do we get the maximum number of shots on goal, as Tony Fauci emphasized at one of our recent webinars. And that's on the next slide. We're moving from what it has been traditionally a linear and uncertain process for going from a promising idea for a medical therapy to demonstrating that it works in people to making it available at large scale to what we're calling a hyper-parallel process where you do all of these things at once, not compromise the evidence on safety and effectiveness, but massively reduce the time by putting these steps together rather than just doing them sequentially. So creating a clear pathway for product development and regulation by FDA and other global regulatory agencies working together around the right standards for determining whether a treatment is safe and effective, by doing clinical trials much more efficiently by setting up networks where Duke has been helping lead these efforts around the country and around the world so that when a treatment is ready to be tested in people, you can go do it quickly. And for the virus, that's especially challenging because we don't know, for example, in July or August, when some of the early vaccines will be ready for clinical testing, where the virus will be most active. So we need to have the capacity to move a trial to where it's needed. And that means getting healthcare organizations to work together much more efficiently than they have in the past in terms of how they can efficiently show that a treatment is safe and effective and get a lot more patients who want to participate in research enrolled in these efforts. And at the same time, not waiting until we see whether a treatment works or not to start the manufacturing of it. And remember, for vaccines, we need hundreds of millions of doses in the US and billions worldwide to really contain the pandemic. but starting that process now. So we've seen some early steps the federal government's taken with manufacturers to build out this capacity early, so that there will be no or minimal delay between the time that you show a treatment works and the time that it can be distributed to the people, starting with high-risk individuals like healthcare workers and essential workers, and then others, as we get more evidence, get that distributed as quickly as possible. And this is with multiple shots on goal. So we're going to be paying billions of dollars potentially for vaccines that don't work to maximize our opportunities to get a set of vaccines that do work well enough to really contain this pandemic in a matter of months. This is a different way of doing biomedical innovation, much less linear, hyper-parallel. And all this is going to matter for the future. We think we're not going back, as you see on the next slide, to where we were before. Healthcare will be different. Hopefully, we'll never have to live through anything like this again, because we'll be better prepared. Healthcare will be redesigned. I talked about some of the directions that we're taking now. And there's some new ways of both developing and then paying for medical therapies with the focus on making them available as quickly as possible at the population level, that we can also learn from this experience. So that's the work ahead for the center. And of course, we want to train healthcare leaders in the future for doing that as well. And I'd like to open this up now to a discussion with David Rubenstein. David, thank you so much for joining us today, and really appreciate your leadership in so many areas, particularly in helping Duke think about and play a leading role in these very important national and global policy challenges.
Thank you very much, Mark, for that interesting explanation. For those who don't know Mark, let me just say that he has an incredible background. I'll give it in 30 seconds. He has only one flaw in the background. I'll tell you what it is. He is from Texas, undergraduate major in English and biology from the University of Texas. Then he went to Harvard and got a MD from Harvard MIT joint program. Then he got a PhD from MIT. Then he got a master's in public administration from the Kennedy School. I was going to ask you, did your parents think you had enough education when you had all those degrees? Did they ever say to you, you have too many degrees?
Yeah, at some point. But,
okay.
But they've eased up on me lately.
All right. And then from there, he worked at the Treasury Department as a Deputy Assistant Secretary of Economic Policy, worked at the Council of Economic Advisors as a member. He worked as the head of the Medicare and Medicaid part of HHS. He also became the head of the Food and Drug Administration. And then more recently, he's been the head of Brookings Healthcare Program before he came to this program. So that's very incredible background. The only flaw in it, as I mentioned, is you don't have a Duke degree, but you are making up for that with all the things you're doing for Duke now. So thank you very much on behalf of all the Dukies.
Thanks, David. I appreciate it.
Mark, in hindsight, is there something that Chinese could have done better to prevent this virus from escaping from China?
Definitely. I think the early response where we actually collaborate with researchers from China, including from the Chinese CDC, and those leaders were out early, recognizing that there was an outbreak and that further steps to containment were needed. Unfortunately, at that point, the economic concerns and the usual reporting structure for the local governments took precedence. And this is something that you see happen a lot in a pandemic. You're always often a couple of steps behind, where in retrospect, you think you should be to contain it, because you're looking at, by the time you take these steps, especially with this outbreak, so much asymptomatic transmission, it becomes very hard to contain. Since then, I think the response has been better and the collaboration's been better. We've certainly had some good dialogue.
Now, there's a report yesterday by a scientist, I think from Oxford, who said that this virus is almost perfectly designed to infect humans. It's almost not possible to think that it could have come from something other than a human design. Do you think that's true, that this could have been human designed and escaped from the Wuhan facility, or you think it was just from bats or some other animal?
David, I haven't seen any compelling evidence to suggest that. Of course, there may be some classified or other information that we don't have available. I'm glad that the World Health Organization is taking a deeper look into these issues at this point. We're really focused for the moment, at least, on dealing with the forward problems. But it is a really challenging virus because it transmits so easily. I think the only good news about the virus is that people do seem to mount good immune responses to it, and that's very promising for the success of a vaccine.
So in this country, without casting aspersions on anybody or any organization, what should we have done differently than what we did? Or would you say there's nothing we could have done differently?
I do think there always are things you could have done differently, and they're generally in the category of doing sooner the things that you recognize are important to do. As there have been some recent studies showing an earlier lockdown, earlier steps to go into these extreme physical isolation approaches would have been helpful in containing the spread. Of course, there's always the worry on the other side that you're acting too soon. But again, this is a virus that's turned out to be very dangerous. As I said, we did a lot of work early on trying to improve testing. I think now we're seeing some wider availability of good tests that are going to get more accurate in the coming weeks. It would have been great if that had been available a month or two sooner. But we're really focused on looking forward and dealing with the challenges from
the great flu influenza of 1918, also called the Spanish flu. There has never been a vaccine for that influenza, and we still don't have a vaccine for HIV. So why are people optimistic that we're going to get a vaccine for this virus? Why are we so optimistic?
It's a great question. I think the reason for optimism is this does look like a virus where people mount strong immune responses, and we've seen that by the large number of people who have recovered and have tests showing that they've got antibodies in their systems that can neutralize the virus. It's not clear how long those last, but it's a really good sign that a vaccine can work. Also, some of the early clinical tests and animal tests for the vaccines that are now moving into broader clinical testing have been encouraging. I wouldn't say perfect, but definitely encouraging. But David, I think the main reason I think this will be different is this hyper parallel approach that I mentioned. Because the pandemic's impact is so big, we are spending a lot more resources on getting this right and doing it quickly. So that means development and clinical testing and large-scale production for multiple vaccines, at least 5, maybe 10 or more in the United States and in other countries, and with support from the Gates Foundation and international collaborations like CEPI. That's going to not cut corners on safety and effectiveness of vaccines, but really reduce the time to large-scale availability. The big if is if these vaccines actually do work, and we just don't know yet, but I think there are reasons for encouragement.
Now, as the former FDA commissioner, your responsibility was to approve drugs, and phase 3 and drug approval usually can involve 3,000 humans or more and take 2 or 3 years. So how are we going to get through a phase 3 so quickly with this vaccine?
Great question. And for the vaccines, it's probably not going to be 3,000 people. It's going to be 15, 20,000 people, because you're giving the vaccine to people who are generally healthy. You're looking for not only do they mount an immune response, as we were talking about earlier, but does that immune response actually protect them? Does it reduce the rate at which they get infected, or at least reduce the severity of infection? So these studies not only need to be large, but they're going to have to take place where there is a significant activity, significant outbreak in a community, and healthcare workers and others have a significant risk of exposure. And that is going to happen more quickly because of steps like setting up a clinical trial network ahead of time, one that can be deployed or one that can be carried out wherever in the U.S. there happens to be the biggest outbreaks at the time, and also can be coordinated internationally. Those trials are not quick. They don't take days because it takes time for people to mount an immune response and to see if it does really protect them, but they can be done in a matter of months. And that's why I think it's possible we could have results and some confidence about these the early vaccines by late this year.
So the U.S. government, NIH, and FDA have funded lots of private sector companies, some in the United States and some overseas. If a vaccine is developed, who owns that vaccine? Dr. Salk didn't patent his vaccine. Why should companies getting money from the U.S. government make a profit on it, why shouldn't it just be free to everybody?
It's a great question, and pricing is another area where we've been doing a lot of work, and our colleagues who work on global issues like Gavin Yamey have been as well. The goal, David, should be broad availability of vaccine to everyone, but that means getting billions of doses made quickly at an unprecedented time. So that's the other piece. We got to get the manufacturing scaled up. To do that, companies are going at joint risk with governments. The US government is investing in this, the Chinese government, the British government, a collaboration across the European Union. Even so, I think we need to be spending more than we are. But the way these production models are going to work is that the companies, for a fee set in advance, and it looks like from the early examples, like with AstraZeneca and the Oxford vaccine, it's going to be about $2 to $3 per dose, will commit to manufacturing literally hundreds of millions of doses by the end of this year, before we even know if the vaccine works, and then the capacity for a lot more manufacturing if other countries do this as well at the same time or soon after. So this is a different model for drug pricing, one that's not about how much we pay for each specific unit of vaccine, but how do we make sure there's enough available if it really does work to handle a bad outbreak, a relatively well-contained outbreak. It's a different model of drug pricing. I think it is going to have some impact in the future as we try to move towards this bigger emphasis on population health.
Now, Mark, you are a teenager compared to me. So I am an aging baby boomer. Why am I more likely to get very ill if I get this than you would be? What is it about the virus that attacks, let's say, older people like me's lungs? What is it that is so unique for older people, or is it just that they're older? That's just a fact of life. Is that why we're getting sick?
It really is incredible how strong a predictor of serious reactions age is for this vaccine. Other factors matter too, whether you have lung disease, heart disease, other conditions, but age is just incredibly strong predictor of risk. Unfortunately and David, you still seem pretty young to me, but unfortunately for those of us who are getting older. And while we don't fully understand the virus, this has only been around for a few months, it looks like this is a result of an interaction between the immune reaction of the body and the virus itself. So it may be that, and this is now I'm totally speculating, that people who have been around longer have been exposed to more coronaviruses before, more colds, et cetera. And so they have cross-reactivity. They mount an especially strong immune response. And so that's what leads to the serious complications. They kind of overly excite their lung tissues and other reactions in the body that cause organ damage and failure. And so that's why there's some interest in and some opportunity around treatments in the shorter term before we get a vaccine that could mitigate the seriousness of these complications.
If I want to prevent myself from getting this, can you hear me, Mark?
I can.
What about hydroxychloroquine? Should I be, taking a couple of those pills a day? Is that going to help me?
Yeah, despite President Trump's use, I wouldn't recommend it. There is no compelling evidence from those clinical trials that I was talking about earlier that hydroxychloroquine does work. And from a lot of the studies that have been done, it looks like it's associated with worse outcomes, especially for people with underlying heart disease. So an effective treatment for other autoimmune conditions, but not yet proven for this one. And David, this just goes to the point I made earlier about how critically important it is to improve our capacity for doing randomized studies, for doing clinical trials of treatments quickly. There are a lot of potential treatments that could work. We've gotten randomized studies done of remdesivir. That does look like it works, published this week in the New England Journal of Medicine. It's not a cure, but it does mitigate, and that's the way that medical progress happens. You find treatments that are promising, you do clinical studies as quickly as possible. In this case, we want them done in days to weeks, not months to years, and then you build on those over time.
Right. Now, with the great flu influenza of 1918, if you read the book that was written by John Barry on it, he said the three techniques that were used that then 100 years ago were social distancing, wearing masks, and washing your hands a lot. So after 100 years, we don't really have anything else. Is that a surprise to you?
Not at all. I mean, that's just the definition of a pandemic. A pandemic is caused by a virus or other agent for which you have no effective medical treatment. So we're trying to make those treatments available and effective treatments available as quickly as possible. But in the meantime, those are the steps that matter. David, I think this is a little bit different than 1918, well, a lot different in that our diagnostic technologies are much better too. So we have the potential over the coming weeks to make tests available for millions of Americans, do a better job of identifying where the virus is hiding, and to do a much better job with contact tracing of containing outbreaks when they occur. That's where the U.S. still has a lot of work to do in the coming weeks to get beyond just the traditional, let's just lock down everything and hope for the best.
Now, another author, David Quammen, wrote a book called Spillover, in which he talks about the fact that humans are more interacting with animals than we ever did before, because there's 7.5 billion of us on the face of the earth. And he says more and more pandemics are likely. Do you subscribe to that theory or not?
They're absolutely likely. We did in my time in government pandemic preparedness exercises. There have been periodic such war game, exactly like war game types activities. How do you establish a big, massive government and maybe international response? So we knew this was coming. Unfortunately, we're not nearly prepared as well as we should. My hope for the future is that with this experience, political parties, both sides, all of us will agree that we never want this to happen again. So that we'll get to a point much more like Singapore or South Korea or Taiwan or Hong Kong. They were hit hard by SARS. It didn't really make it to us. That was an easier pandemic to control, but they were hit so hard by SARS that they went through some intense processes. You can do this in a public system, a private system, a public-private system. There's steps that work. We just need to make sure that we're taking them as a result of this pandemic.
Even with your background, were you surprised at how dependent we are for healthcare supplies on China or other countries? Or did you realize that, but there's nothing you could really have done about it, or anybody could have done about it?
Well, that's a weak point that we really weren't prepared for. So the Strategic National Stockpile had a lot of ventilators, a lot of treatments for respiratory infections that we suspected might be out there. It did not have personal protective equipment at a large scale. It did not have the nasal swabs that ended up being in short supply and slowed down our availability of testing. That's changing now, but it's important to remember that for a pandemic response, this has to happen at very large scale, and the response is going to be limited at every step by the weakest link in the supply chain. So early on, it was availability of ventilators and ICUs and protective equipment. Then it's been availability of the swabs and the reagents needed for the diagnostic test. Next, and we wrote about this past week, it's going to be availability of the therapeutics. We have to do therapeutics at scale. So like remdesivir now, very promising drug available in very limited supply. If we don't ramp up now, not only our capacity to manufacture vaccines, but also the monoclonal antibodies, the other treatments that could work, we're going to see the same kinds of challenges with supply chains when we get to more effective therapies being available.
So on ventilators, everybody was obsessed about ventilators, but if you get on a ventilator, what's your chance of getting off a ventilator? Don't they have a very high fatality rate for those people that go on ventilators with this disease?
Unfortunately, very high rate of fatality. And one of the things that we've learned through studies that are being done using electronic records and healthcare organizations sharing data, something that is happening better than it ever has before, and hopefully this will be another big push forward, is that, David, it turns out to be better to try to keep people with these very serious cases off the ventilators. They seem to be able to tolerate a lower level of oxygen in their blood than most doctors have been comfortable with. And so that means you can use the ventilators less. When you do use them, changing the position, minimizing the amount of air pressure that you're putting into the lungs really does seem to be associated with better outcomes. So hopefully,
we're almost out of time. Final question. If somebody wants to help, if they make a contribution to the Margolis Center, will they likely not get this disease? In other words, is there any relationship between contributing to the Margolis Center and not getting COVID-19? Do you think there's any correlation there?
Well,
that you found yet?
we haven't detected that yet. I would say Duke is doing a lot of work on the research side, and we're pleased to collaborate with them on vaccine development, on development of some of these other therapies, on learning from data about what's working and managing the pandemic,
Okay.
and creating a public health response. What I think I can promise is, for those of you who want to work with the center, go to our website. There are a lot of resources there. I've touched on some of them that hopefully can help you better prepare in your own life for what you're facing now and what's coming with the pandemic.
Thank you.
We really appreciate this.
Thank you, Mark, but that's the wrong answer. The answer was, if you do contribute, you will not get this disease. But okay, I'll turn it over to the students for questions. Thank you.
Okay, David, thanks so much for joining us. I really appreciated the discussion, and thanks for incorporating all of those alumni questions too. So I'm going to turn to Susan Denser now to introduce Sophie and Sahil.
Well, thanks so much, Mark. And as you said earlier, given that part of the center's mission is educating new leaders and emerging leaders, we're delighted to have two of them with us today, two undergraduates. Actually, one of them is a brand new graduate who've worked with the center during their undergraduate careers and actually adapted that work for the COVID-19 pandemic. So let me introduce first Sophie Hurowitz. She's from Washington, D.C. She's a rising junior and a neuroscience major in the Trinity School of Arts and Sciences. She's also pursuing a minor in global health and a certificate in child policy research. And she's one of Duke's Alice Baldwin Scholars, which is a program focused on women's leadership. So Sophie, tell us about your work with the center and how you shifted that amid the pandemic.
Thank you. So I'm Sophie. I have previously worked with the center as a part of a Basque Connections team on policy solutions in support of the North Carolina Early Childhood Action Plan. And now, in the midst of the pandemic, I am currently a researcher and co-author on the COVID-19 State Mitigation Evaluation Project. Our research has examined mitigation measures such as non-essential business closures, school closures, and the stay-at-home orders that each state has enacted in response to the pandemic. Our preliminary outcomes reveal that social distancing did, in fact, prevent millions of cases in the United States. And additionally, our research has shown that states that closed earlier relative to their individual 100-case milestones were much more effective at flattening their own individual curves. We hope to continue this research as states begin to reopen in order to determine the most effective reopening strategies.
And so, Sophie, what was the most interesting or impactful element of this work as far as you're concerned?
My work with the Margolis Center has allowed me to merge my interests in clinical healthcare and population health with interdisciplinary health policy work that I've realized is so connected to our country's larger economic, social, and political climates and even inequities. I'm so grateful to my Margolis faculty mentors for encouraging my growth as a researcher, a team member, and in general as a student. And I'm very much looking forward to continuing to work with the Margolis Center in my 2 remaining years as a Duke student.
Oh, well, that's fantastic. Well, now we're going to hear from Sahil Sandhu, who's from San Jose, California. He just graduated, summa cum laude, I might add, with a self-designed bachelor's degree in health innovation. And he was working on using evidence-based practices to design and implement and evaluate new healthcare innovations. He's also been awarded a Fulbright scholarship that is going to take him to the United Kingdom later this year to earn his master's degree in health services research. So Sahil, same question to you. What was your work prior to the pandemic, and how did you pivot that in the context of the COVID-19 pandemic?
Thanks, Susan. So I'm Sahil. I've really enjoyed working with the Margolis Center for nearly 3 years now. My health policy journey started a few summers ago in Washington, D.C. As a Margolis summer intern. And since then, I've been able to take Dr. McClellan's client-based health policy course. I've been co-president of our new student health policy organization. But my main interest in health policy has been on the integration of healthcare and social care. So we know that non-medical social needs like food insecurity and housing instability are major drivers of health outcomes. And especially during the COVID pandemic, we've seen how rising unemployment and growing social isolation have made these social risk factors matter even more. So now more than ever, I really think that healthcare organizations have to think about how are they going to address their patients' unmet social needs. So 2 years ago, I worked with Margolis faculty to create a new program in which we trained Duke student volunteers to help patients connect with resources in their community to address those unmet needs. And then during the COVID pandemic, we've increased our program's capacity, but have also created this Durham-wide community resource directory that's being used both by the Duke Health System and by social services. And I'm also writing a commentary on some of the ethical considerations that healthcare organizations need to take when thinking about doing this work.
And same question to you that I posed to Sophie. What for you was most impactful about this work?
Yeah, so I came in to Duke 4 years ago, not knowing much about health policy, but I think the big takeaway for me was in order to transform our healthcare system, which is especially needed during the pandemic, we really have to take a multidisciplinary and multi-sector approach. So healthcare providers, government officials, payers, pharmaceutical industry, we all have to come together to think about what are these major challenges and how do we work collaboratively to solve them. So I think that's kind of been the major takeaway for me.
And as you go off to the United Kingdom next year, how are you going to take this work forward?
Yeah, so in the United Kingdom, I'm really trying to understand how does the UK system actually address healthcare and social care integration. I think there's a lot of things that we can learn from their work and the knowledge they've been producing, and bring that back to the US to think about how do we best integrate these two systems together.
Well, both of you, Sahil and Sophie, have described really very important pandemic-related work, and it's entirely consistent with the center's focus on advancing the evidence base to improve the public's health and healthcare, especially at this critical time, as both Mark and Bob Margolis said. So thanks very much to both of you for sharing that with us. Let me turn things back over to Mark McClellan. Mark?
Hi, hey, Sophie, Sahil, and Susan, thank you very much for those very concise presentations. That was great. Susan, you talked about how the center is playing a role not only with students, but with policymakers. You've been around policy and communications for a long time. Can you say a little bit more about what we ought to be focusing on and how this is needed today?
Well, Mark, I think the work you described earlier obviously has just been so essential and so important. To state the obvious, we have had a bit of a leadership vacuum at the top of not just the federal government, but to some degree the state governments. And so it's been really incumbent on entities like the center and your work and your colleagues' work to step in and provide clarity for people about what the steps are that need to be undertaken, to synthesize the science as it is known, to recognize the many uncertainties that we still face us. As you said, we're learning every day about aspects of this virus that we didn't contemplate the day before. So being able to summarize all of that, synthesize it, put it into the white papers and documents, the various communication strategies that the center has used, it's just been critically important. And it's just one of the reasons all of us affiliated with the center are so proud to be making this contribution at this time.
Thanks, Susan, and again, thanks to our students. And behind what you all have heard about and discussed with us today are a lot of people, faculty members at Duke from throughout the university, research analysts with backgrounds in economics, in various aspects of policy analysis, in medicine, and other types of innovation, ethics, and so on. It's a very diverse team that we are able to bring together because of the way that Duke approaches big, complex problems. That's where we started at the outset. That's where Bob started and his, and Bob Margolis and Lisa Margolis and their desire to fund a different kind of Center. We hope that you've enjoyed this discussion today, and we hope that you'll stay tuned because, as you've just heard, we are by no means done with the pandemic, either in terms of effective responses in the United States or globally. And we're going to continue with our work on webinars, on reports, on publications, and other types of output that we hope you'll find helpful. If you'd like to learn more about the center, as David pointed out, I can't guarantee you a cure for COVID-19, but I sure can guarantee you some interesting opportunities to engage and find out more about not only where we are, but anticipating where we're going to be headed and how we can get through those next steps as effectively as possible. Our website, healthpolicy.duke.edu, or just go to Duke-Margolis on the web. Will take you to our COVID-19 work and some information about getting on our list and finding out more about what the center is going to be doing in the future on these topics, as well as how you can work with us more closely. In the meantime, thank you very much for joining us today. Please stay safe as we continue to make our way through this very challenging national and global public health emergency, and take care.